Hi, everybody. Thank you very much to the SMSNA board for the invite. It's a great pleasure to be here. Faisal Yafi told me that he's coming to my talk so that he can laugh at me. And that's the kind of support that I like. So if you would also like to laugh, please do so. I'd appreciate if you could do it quietly. He's waving over there. Appreciate that. So here we go, grafting in 10 minutes. So I'll do my very best. These are my disclosures. So what are the indications for grafting? Well, I think most of us in this room who perform grafting know all about that. I was always taught conventionally that it's for complex curvatures. And what's a complex curvature? Conventionally, that was the 60-degree mark. Certainly when we're revising for our exam in the UK, we're always told it's either over 60 or less than 60. You and I both know that it's a bit more nuanced than that. If a patient comes along with a 55-degree curvature, I'm not suddenly going to say there's no way that you can't have a grafting procedure. And likewise, somebody could come along with a 70-degree curvature and might do very well with a plication corporoplasty. Significant shaft narrowing is certainly something very prominent in my mind when I see these people, because that's something that may benefit from a graft, but equally, doing a graft in someone who's got significant narrowing may make things much worse. Always look for the hinge defect, of course, and then try and make an assessment about how extensive that plaque formation is. So what's the challenge ahead? For me, in grafting, they're probably the most important group in terms of patient selection. Plication, you're probably not going to do that much harm, and an implant does exactly what it says on the box. But for these patients, I think they have to be counseled incredibly carefully. That means volume. And in the UK, clearly that means a lot less than it does here in the States, but nonetheless, it should be a high-volume center. And in my opinion, this surgery cannot be rushed. You have to be in the right mindset to perform this operation. The patient must have good erections, in my opinion, as well. So if someone comes along to me and says, I'm taking PDE5 inhibitors, or I'm having to use a vacuum device, etc., straight away in my mind, I'm thinking, maybe you're not the right person for this operation. Why is that? Well, because we know the risk profile of this operation is significantly higher. We know that the ED rates are higher, glands numbness, palpable grafts, and graft contracture. People often describe it as lengthening procedure. I try and get all my trainees not to do that, because as soon as a patient hears the word lengthening, that's all they heard. They don't hear anything else. They expect a bigger penis when they leave the OR. So this is what we know. We know that actually grafting, when done properly in the right patient, does result in significant straightening for the vast majority of patients, but not all. In terms of ED, the data is pretty heterogeneous, okay? So we know it can be anything from 5%. I think if you're regularly grafting and getting a 5% ED rate, you're doing something very right. And I'm very impressed, and I'd love to speak to you. And we also know that it can go up to about 50%. The follow-up varies in all the studies. This was a literature review that came out of the south of England. I felt I had to pick something from home. So 12 studies, over 1,000 patients. And again, it just reinstates what we're talking about. The vast majority of these patients will require pharmacological help in terms of their recovery. And I think we have to be very clear about that when we speak to them. 1 in 10 or so may not develop an erection. And certainly when I consent these people, I make it very clear to them that they may well need a penile implant. And okay, they might not need it at year 1, 2, 3, 5, but they may well need it beyond that, because eventually they might develop significant veno-occlusive dysfunction. What do we want in terms of a graft? Well, we want it all, right? We're surgeons, so we want everything now. It's impossible. So you want the elasticity, the resistance, and you want it not to cause veno-occlusive dysfunction. And if you look at all the studies, there really isn't a graft that kind of exists that hits all of those. We don't use synthetic materials anymore. I know there's been a lot of use of things like xenografts, and certainly in the UK, I still use a bovine pericardial graft, which I stitch in. I don't have a great deal of experience with Tacocil, but I know that there's varied experience around the room. So current recommendations, I think you're on safe ground if you use, bovine pericardial graft. You know what it is, you know what it's going to do, and in terms of literature, that's where the longest term data exists. There are, of course, several other options, and I've gone through those there. Buccal mucosa, limited reports, but people have essentially tried to use everything they can to try and give you the optimal outcome. Incision types, now that's really important, isn't it? Because you've got to think about why you're there in the first place. What are you trying to do? Are you trying to straighten the penis? Are you trying to widen it? Or are you trying to do both? So your incision is very, very important. And that's something that I try and speak to the patient about before, to try and be very realistic about expectation setting. Because that's the thing that causes the problem here. It's the expectation versus the delivery, as it always is in surgery. The most common incision type I make is the so-called double Y, which is B in the picture there, lifting the neurovascular bundle off. So here's a patient of mine. So this is a patient that absolutely wasn't up for the idea of application because didn't want to tolerate any level of length loss whatsoever. So that's a pretty conventional technique. I'm sure we've all seen it in the room. I've lifted the neurovascular bundle off there and made my 2Y marking. Followed by that, you put the graft in, put bucks back together. And just to make your picture look very good, what you do is you get the gland stitch and you pull it up in the air so it looks really straight for a conference talk. So that's what happens when you create the defect in the plaque. You make the incision, and there you go. It springs wide open. You've now got to go in there, measure that, and make an assessment. Generally oversize as opposed to undersize, because oversizing is forgiving, undersizing is not. All you're going to do is create a new plaque formation. Ventral tunicle grafting, very, very difficult. So why? Thankfully, we don't see many of these patients, and aren't we lucky that we don't? Because ventral grafting generally, conventionally, is not something that's been recommended. If you are going to do it, you need to find a very specific kind of patient where the plaque formation is very much ventral. You need to lift that urethra off and then wrap it under and put the urethra back on. It's high-stakes surgery, so if you're having to do that, I think, again, all your time, you need to spend as much time consenting them and counseling them as you do doing the operation. So this, I think, is a video. So it should work, I hope. Are you able to just give that a click? So it's a very quick video, courtesy of one of my mentors, David Ralph. So here you've got a patient who basically does have a graft, but then has another one on top in order to give some added width to that. So a lot of people talk about extra tunicle grafting. I think the jury's still out. Why are you doing it? It's not going to give you any enhanced outcome as far as I'm concerned. And it's all about axial rigidity. So if the axial rigidity doesn't exist, I don't think doing an extra tunicle graft is going to introduce that. It's pretty much cosmetic, really. What about lateral grafting? So again, thankfully, we don't see many of these, but it can be done. So there you can see the classical wasting that you get in the penis. And what do you need to do? You do the same thing that you normally do. You mobilize that neurovascular bundle, move everything from lateral to medial, and then make your Y incision. And that's a pretty big graft that's going to need. And again, patient needs to have really, really good erectile dysfunction, because I don't think you could be criticized for putting an implant in this patient if you look at how substantial that narrowing is. So there you go. You put the lateral graft down and the penis looks a bit wider. What about post-op? I think this is one of the most important things. These need to be a highly motivated group of patients. They need to listen to what you're going to tell them to do. If they don't do that, it's going to compromise the outcome of your surgery. So the vast majority in our care go on PDE5 inhibitors as soon as they can. They use a vacuum device or a traction device to try and stretch that graft out, because we don't want graft contracture to essentially create a new plaque for you. And again, I tell all of them, if this doesn't work, we're going to head to an implant in the end. This is an interesting paper from Dr. Mulhall's group. It's historic now, in 2011. I think this was between 60 to 80 patients. And what it basically says is these are the factors that are going to predict or certainly mean that your patient gets an inferior outcome. And it's quite interesting, isn't it? Because actually, who do we do it for? We do it for all these things. They're normally over 55. They normally have some level of veno-occlusive dysfunction, and they normally have a curvature of over 60 degrees. So the take-home from this was they need to be young, make sure there's no venous leak, and if they've got a profound curvature, then don't consider it. So there's a bit of a dichotomy there to think about. If it isn't broken, don't fix it. How many people here would have a grafting procedure? Put your hands up. Less than 10. And so why is it that we tell our patients all the time that this is the right procedure for you? It's always interesting. You go to any conference and you ask, would you have a grafting? And people go, great operation, love to do it, but no thanks. So, patient selection is absolutely key. It's about functionality. The ergonomics talk, which was incredible, by the way, I'm still distracted by that. basically tells you that it needs to be good enough. It doesn't need to be perfect. Peyronie's disease is about introducing functionality, rigidity, and straight enough. Not completely straight and not completely rigid. So we know people with a residual of 15, 20, maybe even 25 degrees can have intercourse. Here's a patient of mine. This is about 12 weeks ago, and this is a patient that absolutely did not want any risk of ED, and that's a patient who had 30 seconds of modeling on the table. So again, food for thought. So in terms of the summary, think again and think some more about who you're going to do this procedure on. It's a fantastic procedure. It's probably my favorite operation because it's intricate and you can get yourself lost in it, and it's nice when it's done well. However, I think the patient selection is absolutely vital, and the patient has to have realistic expectations. We don't really know what the ideal graft is. Rehabilitation is absolutely mandatory, and as is always the case in Peyronie's disease, the data is very heterogeneous. So we really need, perhaps, data that's a little bit more robust than what we have at the moment. Thank you very much.